It never fails. Someone always asks me, "Hey, Heather, what about?" And honestly, that's where the best conversations begin. I'm Heather Shaw, certified functional nutrition coach and Pilates educator. After walking through my own wellness journey, hello 80-pound weight loss, I now light the path through my program, The Plan, complete with protein-forward recipes, hormone know-how, and a lifestyle for longevity. This is the Exquisite House Pilates and Wellness podcast. Hey, Heather, what about? We're diving into all things movement, metabolism, menopause, and more, especially the stuff no one warned us about. I tell it like it is, but always with a wink and a hug. No perfection required, just consistency, curiosity, and better questions, served up with a side of sass. Welcome to the podcast. Today, I have an amazing episode for us. I have actually procured an expert in women's health, and I'm probably making Terri nervous. So this, everybody, is Ms. Terri Page, and she is a nurse practitioner with Virginia Women's Center here in the Richmond area of Virginia. We are going to be discussing all things women's health from the onset of when we start to really dive into our womanhood to, our end stage. So Miss Terri, before we get into all of that, which is going to be, we're going to try to squeeze this in a very short period of time. We're going to do what we can do.
Hey.
There's no perfection in this. It's always sarcasm and silliness and fun when we're here. But talk a little bit about how you got into this and where your passion for women's health came and all of those good things. Share a little about you for us.
Okay. So good afternoon, Heather and audience, and thank you for the invitation to be a guest speaker on your podcast. I'm Terri Page. I am a board-certified advanced practice provider, and I specialize in women's health. I currently work at Virginia Women's Center. I've been there for 18 years now. But my background, I've been a registered nurse for over 18 years. I worked downtown at VCU Health and med-surg, interventional radiology, and labor and delivery. That's definitely where I found my passion to work with women's health issues. And so went back to school and got my master's to become a nurse practitioner. And so I've been a practicing nurse practitioner in women's health for the past 18 years. And then I went back to school in 2017 and got my doctorate in nursing practice at VCU. So kudos to VCU for the trifecta for my undergrad, master's, and my doctorate. And so I've always wanted to be in the healthcare profession, wanted to be a nurse. My role models were my mom and my godmother who worked in the healthcare profession. And so always wanted to help people and always wanted to help women, particularly through their age lifespan. So from infancy, adolescence, into adulthood and gerontology as well. So here
Nice.
I am.
I love that. So you do treat from puberty onward in that's your kind of practice, your scope of practice is really women's health in the gynecological, OB-GYN type of environment. And talk to us. So we had an amazing symposium for World Menopause Day, which I really loved, but I knew that would spark some questions about we all are women, but what actually is going on with these bodies? So can you, can we kind of break down puberty to 20s, 30s and talk about the things that happen? And then we know there's some really hot topics in that time frame for our lives, and maybe we can touch on that a little bit.
Absolutely. We're setting the groundwork for the conversation. I love this, Heather. And like I said, I definitely have a passion for adolescence. It's a really scary time, but yet fulfilling time for women to go through, because you talk about so many different aspects in their healthcare, from birth control to family planning to menstrual cycles, right? So, in 20s and 30s, there's birth control options that I talk about. There's also mood, metabolism changes, nutrition. So I really enjoy talking to young women about that lifespan and their lives. So they come see me and, they are definitely terrified about the GYN exam, but I try to calm those fears and just let them know that it's going to be okay. But you have a lot of women who've had traumatic experiences in their past, so you have to definitely just tread very lightly and just talking to them about just the female anatomy and their reproductive health.
Yeah. What should women know about birth control? Because there's a lot, like from when I was back in the day, started down that rabbit hole. And believe me, I was young and like, oh my gosh, this stuff is making me crazy. What's improved? What's changed? And what are the options?
So you have multiple options. Of course, you've got the oldie but goodie. You've got the birth control pill, and most of the birth control options, they not only just regulate pregnancy, but they can also help with other symptoms like premenstrual syndrome. They can also help regulate cycles. They can help with acne. They can help with mood swings. So most birth control options are safe when introduced, and introduced, with the various options that are out there. You choose an option, you have that discussion with that person, and you choose an option that best fits them. Because, of course, with any method of contraception, whether it's in the form of a pill, a patch, or a ring, or you have your long acting reversible methods, which are
Yeah.
your IUDs, there's the Nexplanon, there's also Depo-Provera. So there are multiple hormonal options, but you also have non-hormonal options as well. So the main concern that my adolescents have, am I going to gain weight? No, you're
Yeah.
not. Birth control has 0 calories, it has 0 carbohydrates. So, some women are more sensitive to hormones, so their appetite may change. And so that creates, some appetite changes. And when you eat more, you're going to gain weight. But for
Right.
the most part, birth control options do not cause weight gain. If anything, they're going to help regulate cycles. They're going to help lessen your flow. I mean, they're going to help with severe cramping. So there are a lot of benefits to birth control options. And if you're not a candidate for hormones, then again, you have non-hormonal options such as there's the Paragard IUD. That's a copper-based intrauterine device, and that lasts for up to 10 years. You have
Wow.
your spermacidals. They're still on the market that are safe and
Okay.
effective, right? And then, of course, the condom. The condom is still a safe, effective method to help prevent pregnancy and also to help prevent sexually transmitted infections.
Now, is there a female condom yet?
Yes, yeah, that the female condom is out. Yes, it is. And I'm definitely an advocate for female condoms. I demonstrate to women how to use them. I demonstrate to my women how to use even just a male condom. Absolutely.
Okay.
Yes, they are
Okay.
out on the market, and we do offer free condoms at our clinical setting as well.
Nice. And talk a little bit about that versus like a diaphragm. Is that still a thing?
Wow. Wow, the diaphragm is still available. And I
Okay.
advise my patients who definitely do not want any type of hormone in their system. We talk about the diaphragm in detail, but you have to be fitted for the diaphragm. So
Right.
that isn't a scheduled appointment, and there's different sizes. It's a dome shaped device. It's, most are latex free. And like
Mm-hmm.
I said, various sizes, but you do have to be fitted because you have to use a spermicide with
Right.
the diaphragm.
Yeah.
And then also timing is important too. So once you insert the spermicide around the rim of the diaphragm, you
Mm-hmm.
insert it inside the vagina, just like a tampon. You fold it and you insert it, correctly inside the posterior part of the vagina. And then after you have relations or you're intimate with your partner, it has to remain inserted for at least 6 hours post-coitally. So, yes. So there goes the spontaneity with that.
That's how my son came around. I didn't keep that sucker in there long enough.
But I have women who still come in and they want information about the diaphragm, and they they definitely want to be fitted for the diaphragm, and so that's still a safe and effective method as well. So yeah, but you have so many short acting options too that work so well, that
Mm.
are hormonal related and low dose. I mean, very
Yeah.
low dose. You got the NuvaRing. That's a monthly method that you insert if you're comfortable with your body, your female anatomy, and you're comfortable with inserting tampons. Then you definitely are a candidate for the NuvaRing. You insert
Okay.
that. It's a ring-shaped device. You insert it inside the vagina. You leave it there for 3 weeks. It doesn't fall out because the vaginal walls hold it in place. You can have
Wow.
relations with it. You can also use tampons with it. But the thing about the NuvaRing, once you leave it in for 3 weeks, that week free, you remove it, and that's when you have your withdrawal bleed. So you still have a period, or
Okay.
you can use it continuously. You remove the old NuvaRing and reinsert a new NuvaRing if you want
Okay.
to not have a cycle.
So basically, there's like a whole nother generation of stuff from when you and I were coming
You
of
got
age.
that right, Heather. You got that right. I tell you, I spend, a visit just talking about birth control options, and it can be in person or it can be a virtual visit.
That's amazing. I love that. But because I felt like when I was coming of age, there was just not a lot of options. And the pill was so intense for me. I had such a response to it. I was like, holy cow. And, at the time, just being as naive as I was, I didn't know how to really totally advocate for myself. So I'm so glad that things have changed for young women so that they're not experiencing what us Gen Xers were like. We felt
Yeah.
like we were raised by wolves, and then we're thrown to the wolves when it comes to our, how to protect ourselves sexually. It was like, oh my gosh, what are we doing? So this is great. I'm excited to hear this. So the other thing that we start to see in that time frame as women are going through puberty and then kind of entering their 20s and 30s is we start to see some of those like female health conditions. So we're looking at like PCOS, PMDD, those types of things. Where are we with treatments and best practices for those?
So for PMDD, which is premenstrual dysphoric disorder, it definitely is real. It's a real symptom and a real condition that women go through. And most women will experience it about 1 to 2 weeks before their cycle starts. Again, you start having mood swings, you start having, cravings, you start having menstrual cramping. But some women become very, very depressed or anxious. So,
Yeah.
the studies have shown that, hormone as far as birth control can definitely help regulate that balance between the estrogen and progesterone when it comes to PMDD.
Yeah.
And also, you can also do cyclic as far as, hormonal advancement. You can also introduce an antidepressant in addition to taking a method of contraception, and that's luteal phasing. You can
Yeah.
also introduce, an SSRI, which is serotonin selective reuptake inhibitor. You can introduce that either 2 weeks prior to your cycle starting, or you can take it continuously. So that way you
Mm.
got the best of both worlds. You got the hormonal balance and you also have the chemical balance. And that I find that to be very effective too. But if women don't want to take it every day, again, like I said, they can take it 2 weeks before the onset of when you see that drop in the hormones. And that's when most women become symptomatic.
Yeah, that's incredible because I know that for me, I probably had something along those lines, just not understanding.
Guilty.
Yeah, we didn't study. I mean,
Guilty.
we weren't studied until what, the
Guilty.
90s. Women weren't included in clinical studies. So for
Yes.
us to even be
Yes.
part of this space where it was like something's off, something's just off, we're not right. I'm
Exactly.
glad that we're starting to see that there's options, that people are recognizing these things, and young ladies now don't have to go through what we went through. So the hot topic for a lot of young people is PCOS.
Mhm.
Understanding polycystic ovarian syndrome is um it's a little bit of a mixed bag in that you're seeing some like metabolic changes that happen with that, and as well as reproductive changes.
I do see that. And we see that a lot in our clinical setting, polycystic ovarian syndrome. And, to simplistically explain it, it's a hormonal imbalance. And it's no longer, women who are obese and or women who come in with beards. I mean, there are a lot of women out here who don't fit the profile. However, they
Yeah.
have other
Yeah.
metabolic changes going on in their body. Not only just hormonal changes, but as far as from a metabolic standpoint, their insulin resistance is up, their hemoglobin A1C is up. So it really does predispose them for developing prediabetes and diabetes. So again, I mean, I just don't slap a pill on them. We talk about other things, because a lot of these women, either they don't have a cycle or their cycles are very irregular.
Right.
So, one option of treatment is going to be, a method of contraception so that their cycles can be more regulated and definitely having that withdrawal bleed, because you don't, as an adolescent or a young adult woman, go through life without having a cycle. That's not
Right.
normal. You have to
Right.
have that withdrawal bleed once a month or every 3 months to shed that lining so it doesn't lead to other complications and later on in life, such as uterine cancer.
Yeah.
So, that's one option that I talk to women about, just regulating the cycles, but also lifestyle changes. Exercise is so important with keeping the numbers down, the blood pressure numbers down, the diabetic numbers down, and
Yeah.
also, it also gives you that mental clarity as far as, because with PCOS also comes, why am I not having cycles? Why am I not even get pregnant? So a lot of women are worried about from a mental standpoint, something wrong with me? Am I broken? And absolutely not. We just got to get the hormones back in balance so that you can start.
Yeah.
We just hit the reset button. You start cycling again once a month. Yeah, everything starts working again.
I like that. So with
But I will
conditions
say,
like,
I'm gonna add one thing
yeah,
is if I feel like I'm not managing them properly, I will refer them to either an endocrinologist. Okay, so I know my limits. I know my limits as a nurse practitioner.
yeah, that's the other thing I was going to ask is knowing that PCOS can have that metabolic impact. Are you prescribing some sort of GLP-1 medication to help support that and manage the insulin resistance, or are you referring to an endo, or
I
how is
definitely will
that work?
refer to one of the physicians in the office or to an endocrinologist provider. I do not prescribe the weight loss medications. The one weight loss medication or a metabolic medication that I will start if women are experiencing any irregularity and desire to lose weight would be metformin.
Okay.
But
Okay.
I do not prescribe the GLP-1s. No, I do
Okay.
not. Or the semaglutides.
Yeah, I was curious because I know that there's been some recent studies, and we're jumping ahead, but just from this standpoint, I know that with menopause, they're starting to see that HRT and the GLP-1s tend to be they're becoming a nice standard of care to manage some of the metabolic chaos that comes with that loss of hormones. So I was curious to see if in the metabolic confusion that's at the earlier part of life with something like PCOS, if that's starting to become a standard of care as well.
I do see that as being a standard of care from a best practices standpoint. But like I said, at that point, that's when I am definitely referring to one of our weight and wellness providers that we have at Virginia Women's Center or to one of the endocrinologists who are in the community who
I like
specialize
that.
in that. Yes. And not
Yeah.
saying that an advanced practice provider can't prescribe the weight loss medication. That's just not my specialty.
Yeah. I like that. So when we're looking at these types of conditions, so the PMDD, the PCOS, at some point in our women's health history, hysterectomy was an option. So is that still something that is offered, or are we dealing with those types of things differently now?
We are definitely looking at those types of diagnoses through a different lens. So yeah, hysterectomy would be definitely one of the last resorts, unless a woman is just having severe pelvic conditions with pain or with bleeding options. But there are so many other options to discuss before even getting to that type of surgery where you're just radically removing a woman's uterus and
Yeah.
her ability to reproduce.
Yeah. Yeah.
Yeah.
I'm glad. I'm
Yes.
glad because I know that that can be a thing. And so that also, of course, brings us right into what happens with fertility, heavy bleeding shifts. We're looking at like fibroids,
Oh,
endometriosis,
absolutely.
adenomyosis. So can we go into that a little bit? What happens with those conditions and then how that's kind of what the standard of care is now?
Well, with I see women, especially women of color, who come in and see me with uterine fibroids, which are benign tumors, but those tumors can wreak havoc, Heather, as far as bleeding, pelvic pain, heavy cycles, painful cycles. I mean, it can
Yeah.
disrupt your life, your lifestyle once a month. However, women think that the number one symptom of uterine fibroids is bleeding, but the number one symptom for uterine fibroids, because of the amount and the number and the type, they put pressure on your bladder. So urinary frequency is the number one symptom. And that's a test question on exams. Yes, it is. It's uterine
Wow.
frequency because of the pressure of those fibers on your bladder. It makes you go to the
Wow.
bathroom frequently. But
Yeah.
again, women come to see me for these fibers, and I do their, of course, I get their history, but then when I do their pelvic exam, I mean, that uterus feels so solid and so enlarged. I mean, it makes these women look like they're pregnant. I mean, 12-week size uterus, 20-week size uterus. So at that point,
Wow.
of course, I order a lab panel to see if they are anemic. And then I order a GYN ultrasound. And then I definitely set that visit up with the physician. Because at
Yeah.
that point, the physician will go over their ultrasound and they will go over the plan of care. But before we even get to that, we do go over different options. For example, based on the amount and the size, there are options as far as controlling, the uterine fibroids and managing them, either with a method of contraception, if they're open to that, especially if they still want to have kids. And most
Mm-hmm.
women, they're in their perimenopausal stage or reproductive stage where they're still cycling and they're
Yeah.
still trying to conceive in the future. But we need to see exactly what's going on with those uterine fibroids before we get to that step. So if we have to remove the fibroids, leave the uterus intact, but leave the uterine fibroid, take the fibroids out, I'm sorry, then that is an option. That's called a myomectomy,
Okay.
where they can do it invasively, they can do it laparoscopically, or they can be an abdominal surgery at that point where they remove the fibroids. And then that will optimize a woman's chance of being able to get pregnant in the future. Because with those multiple fibers, sometimes it could interfere with a woman's fertility.
Mm-hmm. Mm-hmm.
You got
Yeah, it
extra babies
definitely can.
growing in there that don't need to be there.
Exactly. So can you describe what that kind of endometriosis or fibroids, what that is or how that develops?
Well, and they're two separate, entities.
Yeah.
Uterine fibroids are, like I said, non-cancerous tumors. Endometriosis is where you have the inflammatory tissue that grows inside the uterus. But study shows that endometriosis, implants can definitely develop on your bladder, your diaphragm, your brain, your ovaries, and they just cause a severe amount of pain. And also they can cause, severe amount of heavy bleeding too. So, but the golden standard still for endometriosis is definitely a laparoscopic surgery to find those endometrial implants. But when women present with the symptoms, you listen and you hear what they're talking about in terms of, my cycles are painful, I'm having pain with sex. So you have to differentiate the two because they're two
Yeah.
different diagnoses, endometriosis and uterine fibroids, but they definitely can have, devastating effects on a woman as far as her reproductive health.
And so is the diagnosis done with that ultrasound then?
For uterine fibroids, yes. For uterine fibroids, yes. They can with a GYN ultrasound, they can transvaginally insert the wand inside the vagina, and they can definitely determine the number of uterine fibroids and the type. Full disclaimer, I definitely had a history of uterine fibroids when I was definitely growing up, and then in my 20s. I mean, my cycles were horrible. I mean, I had heavy
Yeah.
periods. I was, my iron levels were low. My iron level got as low as 6. I had to end up with blood transfusion, IV infusions until
Gosh.
my first surgery was a myomectomy, and that is where the uterine fibers were removed. But I still was able to, keep my uterus intact because at that time I was 27 years old and I wanted to have kids.
Yeah.
So I did not
Yeah.
want that option taken away from me. So, and thankfully, they were able to, just remove the fibroids, but leave the uterus intact so that I at least have children in the future. And I have had two. I have two kids. I have a daughter and a son, thankfully. So yeah,
Good.
but yeah, like I said, those fibers can wreak havoc. And so eventually, if the fibers are so huge and you can't remove the fibroid, then some women are definitely left with the decision to move forward with a hysterectomy.
Yeah. Yeah. And I I have a personal experience with all of this too. So my mom had a fibroid and she ended up having to have a hysterectomy. Well, she was probably a little bit younger than me, but I had adenomyosis.
Mm.
So we know like that and endometriosis are similar in their behavior, but that was the other thing that I wanted to know was how now are they is that diagnosed? That was the question
Yeah,
I had for her.
adenomyosis, where the uterine lining definitely is growing inward, it definitely is diagnosed by a GYN ultrasound.
Yes.
Yes, and not too long ago, I had a patient, wanted to definitely, insert an intrauterine device, an IUD, but she was having heavy periods, passing large blood clots, losing large amount of blood. So, of course, I consulted with the physician, and we ordered the ultrasound. And then when the ultrasound report came back, that same day, she reviewed it with me. She said, "This is what adenomyosis looks like, Terry," and you could just see it, the thickening of that
Yeah.
uterine lining. And
Yeah.
so, right then and there, we were able to insert an intrauterine device inside this lady so we could try and thin out that uterine lining.
Wow.
So
So
that's one of the,
that's
yeah,
okay.
that was an option for her at that particular time.
That's amazing. That's amazing because I mean, for me, it was like I went through, gosh, a year of just constantly being, I mean, my doctor and I were like, okay, are we going to lunch after this? It's like we were in it. We were in the thick of it. But I think about like, I know that things have changed so much. I mean,
Mhm.
I was had to make the difficult choice of having a hysterectomy at 32. Um, after spending all of that time, and it really was the best choice for me. I was miserable as a pregnant person, and I can, hindsight being clear vision, definitely noticed that I think just the hormonal shifts for me were really challenging. So
Yeah,
I was
yeah.
sick, eight out of 9 months. I was very nauseous and had all the things. It was just like, oh man, this is not my favorite thing to do. But I know that things have improved from where we were. And I know that for me, I had a wonderful doctor who took great care of me. And I was very thankful to have her. But we went through a very long process before we ultimately determined that a hysterectomy was the best option.
Okay.
And I feel like that she did the right thing there for sure, because it isn't just about just take all this stuff out. And I
Right,
know a lot
right,
of women,
right,
when they
right,
start to get
right,
frustrated, they're like, why am I going through this? But
right.
there's so many treatment options now that we're not stuck in this end stage of like, this is the ultimate of what we have to do to get rid of this or have a good quality of life.
Correct. And that's the key word right there, quality of life. And you have some women like, Terry, you know, take it out, take everything out. I say, well, I'm not a surgeon. Okay. I can't take everything out. I'm tired of bleeding. I'm tired of being in pain. So you do have that group of women who do come in and they directly ask to have a hysterectomy. I said, well, let's explore some other options. But these are the steps that we have to go through first before we get to something as radical as a hysterectomy, because you got to be careful what you ask for. you
Right.
know. So
It's true.
exactly. So let's get the panel, the lab panel. Let's get the diagnostic imaging, and then let's get you to talk with your physician, and then together, on a partnership basis, you decide
Yeah.
what's best for you.
Exactly. I think that was the best thing I did with my doctor is we really partnered together and just tried to troubleshoot as much as we could. We did a bunch of stuff. I mean, just, we
Yes,
went through the whole battery of things before that
yes.
was the option. And I was really glad that we did that. And knowing, she did some things with like birth control where I didn't have a cycle
Hmm, hmm.
and those kinds of options. And we exhausted every effort. And I think that, this for me kind of starts to talk into where we go with perimenopause and menopause, because we know that as we lose those sex hormones, there can be a thickening of the uterine walls, which then creates that same type of scare or discomfort or, kind of stuff as a patient. And so then again, you start to get to a certain point and you're like, I'm not using this anymore. Why is this still here? Like, can't we take this out? So can we go through from that point, and then we can talk about like all the fun menopause symptoms and all the great treatments that we have now. So can we stay on kind of the uterus and what happens there with?
Absolutely, absolutely. Yes, we can. Yes, we can. So, and again, I just want to say that as a provider, one of the options that I really really hone in on are the intrauterine devices. They are indicated for heavy bleeding, endometriosis, pelvic pain. So with a hormonal intrauterine device like the Mirena, the Kylena, the Liletta, they definitely, once inserted, once you get through the insertion piece, they really do work in terms of just really controlling the bleeding by releasing the progesterone only to the uterine lining to kind of cause it to thin out. Okay, so it does, create like a hostile environment. So it's not like the egg and the sperm unite and then you have a miscarriage. That's not the mechanism behind it.
Right.
It just creates a hostile environment for implantation. And so then women still ovulate with the IUD, whether it's hormonal or non-hormonal. Now with the Paragard, which is copper based, you still have a cycle. So if you still want to have a cycle, your cycle pattern doesn't change. You still have a monthly cycle. But whereas with the hormonal intrauterine devices, your cycles are either going to be very light or non-existent.
That's awesome. And then when we start to go through menopause and we start to see that thickening and we stop menstruating, that then becomes a precursor for potentially uterine cancer, is what we're starting to be concerned about. Okay.
Absolutely.
Can you talk a little bit about that for us?
I can. So, like I said, as we were, born from, average age for have menstruation is age 12. So, to have a cycle monthly, it does withdraw, you have that withdrawal bleeding so they can keep that uterine lining nice and thin. And that's what we like, the uterine lining to be nice and thin. But when that lining starts to build up, build up and build up and build, and you don't have that withdrawal bleed, it leads to a condition called hyperplasia. And the hyperplasia is what leads to uterine cancer. So for women who do come in with that heavy bleeding and passing blood clots, when you have that GYN ultrasound, it can determine how thick that uterine lining is. So for women who come in and they say, I'm just having these heavy periods, Terri, I don't know what to do, So I said, well, let's figure out why you're having these heavy periods first and foremost, and then we can go from there. But, some women who are in that perimenopausal phase and that line is thickening up, the first thing I will do is an endometrial biopsy. So
Okay.
that endometrial biopsy, is a procedure in the office where you get a sample of the uterine lining, you send it off to pathology, and that rules out any type of malignancy. But if there's no malignancy and you still have that thickened lining, we need to thin it out. And one of the options, to thin that uterine lining out is a method of contraception.
Okay.
That the birth control pill can do that. The NuvaRing, Depo can do it. The intrauterine devices, the hormonal intrauterine devices can do it. And also, there's progesterone only pills. So if you're not a candidate for estrogen, because it could lead to, high blood pressure, or blood clots or stroke, of course, there's progesterone only pills too that can also keep that uterine lining thin. So it's important, or a woman who is, maybe jumping the gun, but if she's postmenopausal, meaning, she hasn't had a cycle in at least 12 months, 12 consecutive months, and she comes in with postmenopausal bleeding, yeah, that's a red flag. That is a red flag. So the workup, you do a blood panel, you definitely do an endometrial biopsy in the office, and you set that patient up for a GYN ultrasound with the physician. Because I have had a case where a woman came in and, she said, Terri, I hadn't had a period in over 4 years. And all of a sudden I'm bleeding like I'm starting my periods all over again. So, she's on my schedule. I said, okay, let's get you in. I performed an endometrial biopsy. She's having some spotting. When I insert the speculum, I can see some like dark red blood in the vaginal vault. I introduced a catheter inside the cervix that goes to the uterus, and I get some uterine sample of the tissue, and I send it off to pathology. And then a week later, it did come back showing it was malignant. It was definitely positive for uterine cancer. So at that point, she's sent to the GYN oncologist, and then immediately they set her up for surgery, because at that point, that's an indication for hysterectomy.
Right. And I think this is really important because we go through, as we start perimenopause and then go into menopause, we start to see some erratic bleeding. We also start to see a cessation of bleeding. And it's, to me, the thing that's very interesting, and it almost feels like the beginning of our puberty, in that our hormones are a little all over the place. Our cycles are a little all over the place. We'd like to choke somebody most of the time, or if somebody looks at us wrong, we're going to slap them into the next week. I mean, there's lots like so, but the thing, I mean, that's like the worst. That's all the emotional and like the mental stuff, but the physical stuff, I think, is the stuff that we don't get to talk about enough because we're so focused on the hot flashes, the night sweats, the irregular period stuff that happens. But I think it's vital that we're really digging into this because from a clinical standpoint, there can be some abnormalities happening that we want to pay attention to. So I think, what we're talking about is really key in that we're not just looking at, okay, I'm not sleeping, I'm not doing this, or I have all these symptoms. And we're actually looking at there is a potentially some dysfunction that can happen with the reproductive system that's more than just that hormone loss. And I'm glad that we're kind of talking through that. I think that's vital for people to be able to feel okay to advocate for themselves. I think women's health is changing. I'm very happy that it's changing. People like you being in this really makes it helpful.
I agree with you. It's more personalized. It really is. I mean,
Yeah.
and perimenopause, that's the bridge that leads to menopause. And that can last for up to 10 years. It can start as
Yeah.
early as 35 to 45. And I mean, like you said, there's a whole array of symptoms, physical, mentally, emotionally, that women go through, like besides hot flashes. You say, I may have a few hot flashes there, but Terry, I just don't feel like myself. I hear that a lot. And I said, well, what do you mean you don't feel like, so I said, I'm more anxious, I'm more moody, I'm more angry. And I don't want to go through life just feeling angry all the time.
Yeah.
And so I just need to know, what is going on with my body? Is it changing? Am I crazy? Like, well, no, you're not
Yeah.
crazy. Validate your symptoms. I hear what you're saying. It's not one particular lab work that's going to tell you that you are in menopause. It's all based on your symptoms. So,
Right.
you're not going to be ignored. You have to definitely embrace what's going on because it's a transition that your
Yeah.
body's going through. You're transitioning into menopause,
Yeah.
which
Yeah.
is, it's a biological event. Number one, it's a natural process. And so we have to talk about it. We have to embrace it. And we have to definitely treat the symptoms, not undertreat them, but treat the symptoms. And,
Yeah.
you have so many options out there, but you also have to you have to definitely be your champion too and your advocate. And you have to make some lifestyle changes as well. You can't
Yes.
just think, you say, okay, well, what's going on here? And I just need to shrivel on up and just not enjoy life anymore. Absolutely not.
Yeah,
Absolutely not.
exactly. So, on that note, in the studio, when we have people come and visit, I think we talked about this when we had our little phone call before our interview. I have a wonderful paper that I give everybody that's called the Menopause Symptom Checklist. And so the menopause symptom checklist was something that I found from a gal who is based in the UK, and it gives like a gazillion. It is a full 8.5 by 11 sheet of symptoms, and then it grades them on frequency and intensity. And so it's a wonderful kind of helpful tool for people to advocate for themselves. So of course I had to use it. And when I went into my doctor was like, I don't need this. I already know how to treat you. I'm like, no, this is for me to be able to tell you what's going on. Like, you do need to look at this.
You
She was like,
do. You
okay,
see my
fine. Okay, we'll put it
timeline.
in your chart. But I mean, I would think that if I was you and someone walked in with this piece of paper, you'd be like, thank you. This is great. This is helpful. Because then you know that that person has taken the time to try to understand they're not just losing their mind, which is what most of us think when menopause starts.
Right.
Like,
That's right.
I'm having a mental breakdown, but we're actually going through a physiological change in our body, and that affords us being able to treat. The other thing I wanted to say about that is that most of the time women don't realize when they're perimenopausal what's actually happening. And then that's when I'm usually handing that paper to girls because I'm overhearing them talk after their Pilates class about, oh, this and that and blah, blah. I'm like, girl, let me help you.
That's
Let me
right.
help
That's
you
right.
here.
That's right.
Don't
That's
do it
right.
for me. Do it for you. It's not for my edification. It's for you. But there's definitely something to be said because those women walk away and they're like, I actually got an HRT because you gave me that paper. I'm like, hey, That's a conversation between you and your doctor, but I just know I don't want anybody to go through what I went through because I thought I was losing my mind when I started
Mm, mm.
menopause. So,
You're so right, Heather. Women lose their mind. They feel like they don't lose. They feel like they lose their mind because it's
yeah,
those hormonal fluctuations. You're going through an ever flow of just hormones going up and down because your ovaries are going into ovarian failure. You
right.
know, you're no longer producing the estrogen or the progesterone. So therefore, we all are born with a set of eggs in our lifetime, about a million eggs. Okay. But as we get older, those eggs, they start to diminish, in each decade of our lives, and then when, the ovaries, they just shut down. That's when the brain is like communicating to the ovaries. Okay, this is what we're getting ready to go through. We're getting ready to go through a change of life that you better be ready for. But if not, you're going to have the raging hormone, the hot flashes, the night sweats, the vaginal dryness, the skin changes, the hair loss or hair thinning,
Yeah,
bone loss. So,
right.
it's a whole array of symptoms that women go through that just aren't pleasant. And they just like, my husband can't stand me, my children can't stand me. Women, it's like, I'm getting a divorce, we're sleeping in separate bedrooms. I could just go on and on.
It's true. It's true. And you touched on, so we're talking about the symptoms, and there's so much more to this because there is treatment, there are treatment options, and then there is lifestyle. And you and I both have had the conversation about lifestyle because we know that that is a vital component to how well we navigate this journey.
Yes, yes.
So the big things are exercise and what we put in our mouth, and then our quality of sleep. Anything else that I'm missing in this?
Stress reduction. Stress.
Yes. Thank you.
Stress women come and say, I want my cortisol levels checked. It's just gonna tell you that you're stressed out. So, there's no measurement, no medicine that I can treat you for because we
Right.
have menopausal specialists at Virginia Women's Center. They are certified from the North American Menopause Society. They are certified in menopause. We have seven of them. you know, After your annual, it's not, GYN visits, not just an annual visit. If you feel like you need a more detailed discussion on menopause, we definitely can get you scheduled with one of our menopausal specialists. And they are certified in that field. 45-minute visit. It can be online, it can be in person. And women
Awesome.
are talking about it. It's an old topic, but it is a new conversation. People are talking about this new menopause.
Our generation is saying, no, we're not doing this lying
That's
down.
right.
We're
That's
not.
right. That's right. Gone are the days where you're coming in and you're saying that I'm just a whiny woman. I
And
am
that
not.
personal summer is not part of the
That's
problem.
right.
We're going to get the solution to that.
That's right. So, like you said, all those points you said, Heather, are spot on. The exercise, the nutrition, stress. You got to keep moving. You got to keep
Yeah.
moving.
Yeah.
I've been more busier now in my midlife than I was when I was in my 20s and 30s.
Me too. Me too.
Seriously.
I know.
I
I'm
mean,
with you.
menopause, life doesn't stop. It's not an expiration on life. It should be a springboard, to spring into something new and just reinvent yourself and recreate yourself. But you may need some help doing that. And that's fine. Get a buddy. Do 20 minutes exercise. Join your classes, Heather. You got Pilates. You got wellness instructors and coaches. Just
Yeah.
do something different. You just
Yeah.
be surprised from an emotional, mental, and physical aspect. It will change your life.
Yeah. Yeah. We talk be we talk a lot in the studio. I have a certification in functional nutrition, and so when people walk through the door, they kind of are taken aback by the fact that they walk in, and I'm starting to ask them about their menopause, or if they're in menopause, if they're at that age, because a lot of my women are. Then I say, how are you doing? Have you been, are you menopausal? Are you not menopausal? Where are you in the cycle? And they're like, okay, you're getting awfully personal with me. But I also say, here's what I'll tell you. And the reason that I ask you this is because the first thing that everybody tells me is I want to lose weight. I'm like, okay, great. So weight is not necessarily about exercise. It's not what we grew up with where we can exercise away what we eat.
Right.
It's really about that nutrition piece is 80% of our health. And so if we're not eating well and we're not supporting a good hormonal blood sugar balance, we're going to be in chaos.
That's
And
right.
our body already, as we're losing those hormones, that insulin resistance naturally
Mhm.
rises because
That's right.
those estrogen receptors kind of keep us nice and even, Stephen. And
That's right.
so we see a lot of that confusion. And I'm constantly championing the reality of like what you're putting in your mouth has a lot more impact than what you're doing in this Pilates class.
Mhm.
So
Well
if you're
said.
thinking that this is going to exercise yourself back into your size whatever jeans you wanted
Yes,
to get into,
yes.
we need to have another conversation. So that was the other thing I wanted to talk about is in all of this, you and I are definitely going in the sense of lifestyle because we know that that's a huge impact on this quality of our life through this process. But let's get a little bit into the science and what we can do and where our options are as far as treating everything. The one thing I want to say before we go into that, because I am ready to hear all of your stuff about that, is the standard of care as far as understanding where a woman is really treating symptomatically,
Yeah,
and you've
yeah.
touched on that, but there's not a lab test at this point when we start to go into perimenopause that's really going to start to show. We already know that the hormones are in
Right,
chaos, right? Is
right,
that kind of
right.
where the approach is now?
That is the approach, it's mainly based off of the symptoms, not just, a blood panel, but of course I want to know where your cholesterol levels are. I definitely want to see what that panel looks like. Your iron levels, I want to see that, your insulin resistance, your hemoglobin A1C, because we want to rule out anything, that could lead to a chronic medical condition like hypertension, hyperlipidemia, or even, diabetes. So that's a great baseline right there. But you're going through perimenopause, if you're still cycling, then your hormones are pretty much going to be pretty normal. Your estrogen and your progesterone levels is when they start getting really or changing when you are in your menopause and postmenopausal years is where we see the decline in the estrogen and the progesterone and the testosterone. So,
Right.
you have to approach it differently when you're perimenopause versus in your menopause and postmenopausal phases of your life. So based on, where you are as far as in your 40s, if you're still cycling but they're irregular, then you can still be on a method of contraception because you can still get
Okay.
pregnant during that stage of your
Yes.
irregularity. Okay. So you
Okay.
got to be careful with that. So a low dose method of contraception will help with the regulation, will help with the prevention of pregnancy, and it will help with perimenopausal symptoms because we're
Okay.
going to have that hormonal balance. But again, you have women come in and say, well, I don't want to be on, my husband had a vasectomy. I intentionally wanted to have that method of contraception because I didn't want the hormones. But I said, well, we can't have you having the irregularity or your life is going to just be off kilter. So, we make the recommendations, we make the suggestions, and if they still aren't, open to the idea of restarting, a method of contraception, then that's when we definitely hone in on your lifestyle changes and maybe some herbal supplements that could possibly help with a balance. But
Okay.
at that point, if their levels are as far as the cholesterol's off, your blood pressures are up, they're diabetic, then we definitely send them back to their primary care physicians for management.
Okay.
But,
And
women who, are definitely entering into menopause, which we know that when they no longer have a period for at least 12 months, we can introduce, at that time, other options. We know that hormone replacement therapy is safe, it is
mhm,
effective, against menopausal symptoms such as hot flashes and night sweats. And we know that estrogen also has a protective effect in terms of your
right.
bones, your
Right.
skin, and your brain, because you do have estrogen receptors, like you said, Heather. They're all
Everywhere.
over your body,
Yeah.
women come in, I got the frozen shoulder, or, I get stiff when I walk up. You need the estrogen is responsible for the lubrication part of your
Right.
body, the dry vaginas, you need to replace the estrogen that's been lost. Now, of course, there are women who are not candidates for estrogen, okay? Blood clots, bleeding disorders, they've had some type of cardiovascular event. They are not candidates for hormone replacement therapy, okay? Let's be clear.
Okay.
But there's also other options out there that can help with hot flashes. There's this new medication that kind of blocks the pathway of estrogen. It's called Veoza, okay?
Yes.
That has been shown to help women get through hot flashes and night sweats only. Okay. That's the sole purpose of that medication. However, I do get a baseline cholesterol level and liver enzymes because, one of the things that can be detrimental while taking the Veoza, one of the side is your liver enzymes can go up. So we have to have a
Okay.
baseline and check them every 3 months if they're on the Veoza. But I have women
Okay.
who are on that medication and they do extremely well when it comes to hot flashes and night sweats, especially women, that taboo is still out there. Hormones cause breast cancer, and that is a misconception. That
Yeah.
is a myth. That is a myth. Breast cancer is not caused by estrogen. It's not. You may have a sensitivity to estrogen, but what causes breast cancer in most women is going to be, we just keep on living. Keep on living.
Right.
Okay.
Right.
Now, of course, if there's a family history, women say, well, can I still take hormone replacement therapy if I have a history of breast cancer in my family? Yes, you can.
Thank you. Say that again,
You
please.
can
Shout that
take
from the
hormone
rooftop.
replacement therapy even if there's a family history of breast cancer. And there's some new data out there now that some women with like stage 0 breast cancer, they can collaborate with the oncology team and the gynecologist, and they are still going to be candidates for estrogen replacement therapy too, or hormone replacement
That
therapy.
is incredible.
Isn't that
So I'm,
groundbreaking? That's groundbreaking right there. So a lot of women are being
yeah,
undertreated or not treated because of the fear. I mean, and that was all brought on by the Women's Health Initiative study that was initiated back in 2002. That was a $1 billion project, large project, sponsored by the National Institute of Health. And, at the end of the day, they stopped it. Where they stopped it early because, some researchers had found that the progesterone and estrogen arm of the study was leading to women who had breast cancer. But the
but they
average,
weren't using what we use today.
right,
They were using Premarin. They weren't
correct.
using progesterone.
Correct. And so out of fear, and not continuing with the research, they stopped the study. And of course, as providers and patients, the take home message was hormone replacement therapy caused breast cancer. And that's, nothing further from the truth. At the end of the day, you have to weigh the risk and the benefits before starting a person on hormone replacement therapy. And the
Yeah.
best time to start is within the first 10 years of them being diagnosed with menopause. All right. And
Yeah.
then you monitor them. Do you stop when they get 60? Absolutely not. You want them to have a better quality of life, so you continue to monitor them. I would place someone on I wear a transdermal patch every day, every day,
Me
every day.
too. Me
Okay.
too.
And I tell
Yep.
you, am I going to give it up when I turn 60? Absolutely not.
No way. No way. That sucker's staying on. They're gonna have to bury me with that thing on. I'm
I
like,
want
there
to
is
put,
no way.
that's right. I want a better quality of life. And, I feel my heart is good, my bones are strong. So that's the take home message. You have that discussion with your provider to see if you are, in fact, a candidate based on your history, your risk factors, and then you make a decision together.
Yeah.
But hormone
Yeah.
replacement therapy, they are safe. They are not dangerous.
I love that. So, talk to me about when a woman is perimenopausal and has hormone replacement, because that is an option.
It is an option. It is an option, but if they are still cycling, they're going through perimenopause, then like I said, my go-to is to start them on either a transdermal patch and then add a progesterone if they still have an intact uterus. Okay. But if they are still in perimenopause and they have had, a hysterectomy, then they are candidates for a transdermal patch, which is
Right.
estrogen, estradiol, which is, the
Right.
most functioning estrogen that we as women produce. So yeah, I will start them on during the perimenopause. I certainly will. Absolutely.
Okay. And do does VWC do testosterone replacement?
We do, but we have, like I said, that's you have to tread lightly with that with the testosterone. You definitely have to get, and the menopausal specialists, they definitely will, order the lab work, in terms of a free and a total testosterone, because you got to be careful with that, because if the
Agreed.
testosterone levels get too high while on the testosterone topical cream, because that's how we prescribe it, you
Right.
place it on the
Right.
hairless area daily. It comes in like a canister, and just maybe like a pea-size amount
Hmm.
you apply to your skin, but you have to monitor those testosterone levels, because you don't want women walking around with, facial hair or alopecia or happy voice. Testosterone does provide, libido enhancement, and it does help women with as far as, more energy and
And it helps
muscle
with
tone.
arthralgia.
Yes, it does. Yes, it does. So it has a lot of benefits, and I do have women who come in and they're already on it and they are doing very well. But at that point in time, I said, okay, let's check and see what your levels are, because, I've had one woman, her testosterone levels, they were off the roof, like 500. And that's just entirely too high. And I said, okay, we're going to have to back down. Instead of maybe 2 pumps, do like 1 pump or half a pump. And let's, check your levels again, because it was just getting into a really dangerous level for her.
Yeah. So that brings me to a very controversial topic that you and I will probably love talking about. So the gold standard for hormone replacement is a transdermal patch, progesterone, bioidentical progesterone that is commercially prepared, and it's a pill that we ingest. And then we have vaginal cream and vaginal tablets that
Yes.
we can do intravaginally. And then we have a testosterone cream. Now, the other thing that happens that you and I know, like for me, it feels like a back alley something or other, is pellets.
Mhm. I had that conversation with one of the menopausal specialists in the office yesterday.
Okay.
And she is not a fan, because, you start injecting those pellets. Sure, you need to know what the estrogen levels are, your hormone levels, estrogen, progesterone, testosterone. You start compounding those pellets, and then you insert them and you start having side effects. There's no way to retrieve that pellet.
Right.
So, it's very controversial. I don't prescribe them. We don't
Right.
prescribe them. You may get
Right.
them from like a wellness center. And if that's your preference, and then you just spend a whole lot of money, on those pellets. And then, you got to get your levels checked, and, your
Right.
levels aren't therapeutic, they're
Right.
suboptimal. Then, I mean, you spent a lot of money chasing, as far as, therapeutic levels to get the best results from that pellet. So, yeah.
Yeah, and the thing that I know is that the pellets don't have the same type of time release
Correct.
quality that our hormone
Transdermal,
replacement that
yeah, yeah,
has.
yeah,
Yeah.
yeah. Because the patch, it goes the transdermal patch goes directly into your system, so you know what you're getting. So, one of the providers, shared with me her knowledge base, that, don't start low, Terry. We already know that they're low. Start in the middle, like a,
Right.
transdermal patch. You start as low as 0.25 and go as high as 1, but start in the middle, go 0.5. You can always titrate up or you can always titrate down, but start in the middle. Don't start low, because you want them to feel, you want them to feel better. And you can start feeling better. I know I did. Once I started using my patch, I immediately started feeling, within a week's time, I started feeling better. I slept better. I didn't have as many aches and pains or joint pain. Even my vision, I may be exaggerating, but I just felt like I had more clarity in my vision too. And and I have glasses on. And another thing, the studies were shown now, because vaginal estrogen cream is used to thicken up the vaginal walls and, make things more plumper and thicker, and in case
Mhm.
that basal congestion, so that you can enjoy intimacy. It won't be so dry or painful. Studies now are showing you can use like maybe like a blueberry size of that estrogen cream on your skin, your face. The
Right.
vaginal estrogen
Right.
cream can be used on your
Right.
face.
Right. Yeah. I actually use it on my eyes
Mhm,
at least
mhm.
twice a week, and it's amazing. Like this, the skin around my eyes, I'm shocked. I'm always shocked at how
Yes,
much it
yes.
changes that skin because it plumps it up really well. I'm like, this stuff is gold. And there's now a telemed company that does have their own estrogen face cream, but I
Mm,
mean, we
wow,
won't
wow.
we won't tell the pharmacist why I'm refilling my prescription sooner. That's Alexa.
So another clinical pearl is the vaginal estrogen cream that you use intravaginally, and you can use, 1 gram, 2 gram, up to 3 grams. You can use that twice a week, twice weekly. And it's not systemic, it's localized to the vagina. So it's a local cream for a local problem.
Yes.
So
So we had Robin Lowry, who is a pelvic floor PT, on, and she talked all things pelvic floor, and she talked about application of vaginal estrogen, which I thought was an absolute pearl of wisdom. I love what she talked about because she talked about that there are hormone receptors from the clitoris all the way to the anal, like the connection point right at the anus where the attachment point is at the
Yeah.
tailbone.
Yeah.
And she said, so you take a little bit on your hand, whatever your dose is, you put it in there to get everything nice and juicy in the vaginal opening, and then you go up and down all the way around there. And I will say that for me, I have since, because I mean, you will understand this, but since I had a hysterectomy young at 32, then
Hmm.
my symptoms clinically, they say that symptomatically, some of the GUSM kind of symptoms are a little more problematic when we have that hysterectomy. And so that was part of what drove me to get HRT. When she told me that, and I had gone to her because I was having, frequent UTIs, and I was like, we've got to do something.
Yes. Yes.
I When I went to her, I was like, this has changed my life. Like I got teary in our talk because I was just like, this literally changed everything, that as far as a quality of life and my ability to just feel like a woman again, because
Yes.
it
Yes.
was like the
Yes.
Sahara down there. I was like, what is happening? This is just bizarre. So it was just awful. And I think, we don't talk a lot about the physical changes, but
Mm.
I think we should go into a little bit of that because from an appearance standpoint, things change down there.
Yes, yes, they do. They become just like, as an adolescent or a woman in her 20s and 30s, I mean, that vagina is really, really bright pink and it's got lots of good rugae, vaginal tissue. And, you definitely don't have frequent urinary tract infections. And so when women come in and they are menopausal, postmenopausal, that vaginal tissue looks very pale. Even their cervix, when I'm doing their pap screening, their cervix even looks different. Okay. It's very
Mm,
pale pink. It's a pale coloration that I'm seeing. And then I do the pap. Typically, you shouldn't feel uncomfortable when doing a pap test for cervical cancer screening. But my postmenopausal women, I mean, they feel that spatula and they also feel that cyto
yeah.
brush as I'm
Yeah.
obtaining that pap test. So I said, let's use a little bit of vaginal estrogen cream. It's safe, it's effective. And if you're having frequent urinary tract infections, you can take a blueberry size of that vaginal estrogen cream and place it around your urethra. And I got that from one of our urogynecologists who's at Virginia Women's Center. We have a whole team of two physicians who are Uro-GYN physicians, and they
Good.
specialize in pelvic floor disorders and prolapse for women, pelvic relaxation. And they definitely stand by that best practice. Have your every woman needs vaginal estrogen cream, Terry,
Agreed.
or
Yeah.
keep that pelvic floor nice and strong. Because when I say I'm urinating all the time, I'm getting up in the middle of the night, going to the bathroom. And I said, let's try a little bit of this vaginal estrogen cream. If we have a sample box in the office, I'll give that to them. You may need some external lubrication or moisturizer like coconut oil, olive oil, or Uberlube. But, for that vaginal wall and for that tissue to be stronger and healthier, you definitely need some vaginal estrogen cream.
Yeah. Yeah. So the other thing that happens, which I think is very interesting, is that there's labial changes
Mm-hmm, mm-hmm,
through menopause.
mm-hmm,
So when we're young, we have
mm-hmm.
an outer labia and an inner labia. And then as we go through menopause, that inner labia kind of gets absorbed into the
Correct.
body. It just
Correct.
disappears.
It just disappears. And we call that agglutination. And I have seen it in women, and I mean, I can barely insert a small pediatric speculum inside the vagina to obtain, pap testing or just to take a look on the inside. It is very painful. I advise women, I say, I see the changes, I can see the labia majora, which is the thicker part, but the most of it has pretty much agglutinated, meaning it's really diminishing. It's just
Yeah.
thinner. I mean, it's just really, really thin, very
Yeah.
thin.
Which is another reason why that vaginal estrogen is so helpful because it continues to keep, I always say it keeps things fluffy.
Yes, I like that. Keep it estrogenized. Yes, it does. Yes, it
Exactly.
does.
Yeah. This is helpful because I think that um we're not talking about this stuff as much. Like I'm like, let's talk about all of it
Mhm.
because I don't want anybody to be surprised, and I want to be able to have, um, I like to say, like when my mom was passing, my mom had cancer, and so we got to spend a lot of time together. And so we went through a thing where I said, I don't want to leave anything unsaid. And so that's how I really feel about women's health, is that I don't want things left unsaid. I don't want us to be in a place where we're not having these conversations and not sharing that the tissue
Yes.
changes,
Yes.
that things are different down there. We feel different, and that there are options. And that's the other thing I want to talk about really quick, is like, what other options are there if someone's not eligible for HRT? We talked about like the medicine for the hot flashes and night sweats. And then you and I on the phone
Yes.
talked a little bit
Yeah.
about some other stuff. So talk a little bit about what other things people can do
For vaginal dryness.
for hormone replacement when they're in menopause, when they're
So, oh,
postmenopausal.
absolutely, absolutely. So if they are just really absolutely against taking any kind of hormone replacement therapy for their vasomotor symptoms, then yeah, there are other options. For example, there are over-the-counter herbal supplements. You can take black cohosh. There's evening primrose oil. There's estrogen. So those are some herbal supplements. And they're not FDA approved like the HRT, but they have been shown to help some women get through the menopausal symptoms. So that's one treatment option. Another treatment are your SSRIs, as such as your antidepressants. Zoloft is one, Effexor, Wellbutrin, Lexapro. So those are some other off-label use. Prozac is a huge one that I prescribe, and it really helps women with vasomotor symptoms. It's the
Okay.
off-label use for hot flashes, night sweats. And then the bonus is if you're having anxiety and you're going through life in a
Yeah.
rage and just
Yeah.
happy one minute, sad the next, and the bonus is you have that anti-anxiety effect from the antidepressants or the anti-anxiety
Yeah.
medication. So I have prescribed that, and I prescribe both of them together, or I prescribe hormone replacement therapy by itself, or I prescribe also the SSRIs by themselves, and they work effectively as well.
Good. Good. And that's the thing I think too. Like, I know that sometimes women will not be eligible for HRT. And so there's definitely that place of like, well, now what does that person do? And I would never want to say, well, you just
Correct.
got to lump it. Yeah.
Correct.
I
And,
think
that,
that's
and another other options would be that work on the nerve receptors would be gabapentin. That's another option, and clonidine. That's another option as well.
okay. Okay. Those are good. That's what we want to know, I think, more than anything. And
Absolutely.
then, so we've talked a little bit, gosh, we've talked about so much stuff. Um, I'm like, wow, what didn't we cover? I'm looking at our list here. Um, so for you, when people are in these spaces and places in their life, what are the things that they really say, oh, I need to go see my OB-GYN? Where are those in, especially as we're in that perimenopause, menopausal phase? What are the signs of like, I got to get help?
So the red flags, definitely, if you're from a GYN perspective, if you're having, persistent pelvic pain, that lasts for, more than 24 hours, you're bleeding uncontrollably, and it's not stopping. You're saturating a pad an hour or passing large blood clots. You definitely need to seek help. If you are urinating blood, you definitely need to seek help, from a gynecologist. So yeah, those are some areas of concern and raised red flags. So then also, from a mental standpoint, you feel like you just can't get a control of your life, and you feel like, there's suicidal ideations, then yeah, you definitely need to reach out to somebody, whether
Yeah.
it's a gynecologist or a health crisis line. You definitely need to reach out. Those are definitely some red flags.
Okay. Those are
Yeah,
good because
yeah,
that's what
yeah,
we need
yeah.
to know.
I mean,
What about when we're younger? Going like in our early 20s, 30s, what things do we want to seek help for other than just our regular um our regular checkups? So things that would be red flags at that point.
for
That,
like females who are in their 20s and
mhm,
30s,
mhm.
definitely, and mental health is huge. Mental health now, women come into their gynecologist they think we're their primary care physicians, and we're not, but we're not going to just, dismiss them. And if
Yeah.
they're, if there's a cry for help, but, a lot of anxiety, they, weight loss, just unexplained weight loss in this generation. There's a lot of bullying in the 20s. In my adolescence, cyberbullying, social media. I mean, social
Yeah.
media is huge. Human trafficking. I've had a patient who was a victim of human trafficking, and
Wow.
she spoke out, and there was a cry for help. So, we have resources that are, in place in the office where we can definitely seek help for these women, shelters and hotline crisis. We've had women who've come in who are pregnant and, just don't have anywhere to go. They're homeless. They're homeless. And so, we definitely have to, have resources, social resources in place for them that they can reach out to. Mental health is definitely huge. And since the pandemic, I mean, the world shut down for 2 years, but now everybody is catching up, as far as with their
Yeah.
health. And, of course, if women are coming in, they, I had this young lady, she was 20 years old. She found a lump in her breast, 20 years old,
That's so young.
20 years old. So of course, immediately we have our own mammography department at Virginia Women's So we get her in for an ultrasound because she's, too young to have a mammogram, but we do a diagnostic ultrasound just to rule out anything malignant, and come to find out that, she definitely had a fibroadenoma, which is a benign tumor, but she still had to have it addressed and evaluated and
Yeah.
possibly removed. But, you have women of all ages who come in with breast masses and that need to be evaluated, and or just don't know what they're looking for when it comes to breast exams, self breast
Yeah.
exams. And so we come in and we do the clinical breast exam, and you say, well, I feel this pain or I feel this mass. And, they definitely reach out to us, as providers, since we have our mammography department, if it's anything that is suspicious. And then if they have a biopsy done, they definitely circle back around to us and let us know that, it's been a malignant finding or a benign finding. But I'm so
Mm.
glad that we have that service for women who come
Yeah.
in, and they find, unexpected masses or brain or nipple inversion or nipple discharge or any
Yeah.
type of breast concerns. So, that's another red flag that now I don't care what age you are, you come
Yeah.
in and you
Yeah.
be evaluated. And then, women who come in and they worry about their bone health, they're falling all the time, they're having fractures. We also have a department for bone DEXA scan where you can come in and be
Good.
screened for osteopenia or osteoporosis. So, those are some other risks. We have a strong family history of osteoporosis. Just know your bone health, options. Take your vitamin D, your calcium. And the gold standard age for osteoporosis screening is between 60 and 65. But it can be sooner if there's a strong
Yeah.
family history and you have other risk factors involved too.
Yeah. I love that. I think that, we didn't even touch on breast health because it's kind of,
So happy
I,
Breast Cancer Awareness Month.
it is. I know I'm so focused on menopause. Um, and I think you touched on that really well. I think there's, for for a lot of us, it's very intimidating to come and get your, for lack of a better way to say it, get your boob smashed.
Yeah,
And then you're
yeah,
like, now what do I do? And what
yes,
happens?
yes,
And um, I think that practices like the one that you're in, I feel like they're taking some of the stigma out of breast screening, and I'm very glad of that. And I think there is an art to a mammogram that when the tech is really good at it, you're
yes,
you're
yes,
still going to feel a little bit of smush, but you're not dying. You're not like,
yes,
oh my gosh, get me out of this thing. You're
yeah,
like, it's like, take a breath, you're done.
that's right.
Take a breath, you're
That's right.
done, which I think is magical.
That's right.
And there's something really amazing about that. The other thing that I love now is that the screening has improved.
Yes,
There's
yes,
other options. If a mammogram is not the best options, there's now ultrasounds.
correct, correct.
And then there's also that when there's any kind of abnormality, and for those of us who have dense breasts because we've gone through
Yes,
menopause or we're just a
yes,
little bit more
yes.
busty, then we're able to catch things a lot earlier, which I think is great too. So am I missing anything on the
No,
breast?
you hit the nail on the head. You did. Boom, boom,
Yay.
boom. Mammogram, ultrasound, breast density, and yes, and if you can take it a step further, if they are high risk for higher dense breast tissue, we don't want to miss anything. So now the guidelines say you can definitely have a breast MRI.
Yes.
So those are the
Yes.
guidelines now as well. And we don't have
Good.
the contrast, you know, enhanced type of mammogram, but they do have facilities out there who do offer that service to women. But 2 minutes on each breast, as far as the breast mammogram screening, that's it. 2 minutes, 2 minutes. But yeah, I hear what you're saying. There are women who come in and they're very apprehensive about, getting their breast mammogram. But I stress to them, not every 2 years. The American Breast Cancer Society says breast mammograms are every year. And maybe a little sooner if if there is a significant history of breast cancer in your family. And we do offer the breast cancer
Okay.
genetic testing at Virginia Women's Center to see if you're a high risk for any type of genetic mutation that puts you at a higher risk for developing any type of cancer, not just breast cancer, but any cancer.
That's great. I love that. I think, did we leave anything unsaid? Is there anything that we haven't covered? I feel like we did so good.
I think
We talked about health. We talked
wow,
about the, gyno stuff. We talked about perimenopause and menopause. We talked about
birth
some of the
control.
things that can impact fertility. We talked about puberty and some of the
Mhm,
early things that happen there.
mhm,
Um, that we talked about supplements, which I loved.
mhm,
Um, anything that um, for our listeners, if someone has limited means, what happens with
mhm.
that? Is there an avenue for treatment?
I feel like there are because now with there's new tools, like you were saying. There's digital and there's at home options. So, we offer virtual visits at Virginia Women's Center if there's, a problem with access to getting into the office. Telehealth visit is huge and telemedicine is huge. I just came across, I love shopping on Amazon. Don't judge me. But Amazon has a Amazon Medical
Yes.
One on
Yes.
their website, and you just pay as your visit is a virtual visit, and you pay the same day, and they have medical providers, for any type of complaint you may have, UTI, bacterial vaginosis, any type of respiratory illness. They have providers who you can see face to face and give you a diagnosis and prescribe medication to you. Now, if that's not
Right.
advancement, then I tell you, I don't know what is. But yeah,
Yeah.
telehealth is huge. You have definitely wearable devices that a lot of offices can provide and apps that can track, your cycles, your symptoms and recovery. So
Amazing.
I am definitely for all of that, but it's nothing like having that one-on-one, in-person, face-to-face evaluation and conversation dialogue with your provider who you trust and you definitely have
Yes.
developed a relationship and a rapport with. So
Yes.
that is
Yes.
so important, Heather. So important.
Yeah. Yeah. I think that um that really is the place that we should end on, because I think that in talking through all of this, and this is an amazing conversation that we've had, but I think there's something really key and important about feeling comfortable with the person that you're with. And it may be as simple as just a personality conflict, or it may be that there's something that patient has gone through that they're a little more sensitive. And so they need someone who has a level of compassion that's maybe different from someone they've seen previously. And I really am so grateful for, um, where I'm seeing women's health go, in that people are starting, the practitioners are really much more aware. I mean, when I was a teenager, I just remember the guy I went to, I was like, I
Mm,
do not ever want to go to a male
yeah,
OB-GYN
yeah,
again.
yeah,
And I had to recently in the last year, and the guy was like, I was shocked. I literally wrote a positive review and sent it to the office and was like, this was the nicest, most amazing male gynecologist I've ever seen. And I mean, I've lived on the planet for a minute, so
still
I've had to deal
exists.
with a few, but I was like, this is incredible. And I think that there is an art to interacting with women when we're in this vulnerable place. And it is a place of vulnerability to have your hoo-ha up in the middle of the
Yeah,
world.
absolutely. Absolutely. What I said, I couldn't do your job, Terry. I said, well, I'm focusing on you. That's what I'm focusing.
Right.
This is a service for you.
Yeah.
So we're definitely talking about fitness, nutrition, mental health, sexual wellness. So, I mean, all those
Yeah.
conversations, it's not just an annual visit, that's what your
Yeah.
exam focuses on, the whole person.
Yeah. Yeah. And that makes it so valuable. So Terry, if someone wants to come and see you, then how do they get a hold of you?
They can get a hold of me. Just go to the Virginia Women website and, you can just pull up my bio and pull up my information, contact information, and that's how you can reach me if you want to set an appointment for your GYN or OB needs.
Okay. And I will make sure to put the website in the show notes. And if I can get savvy enough and we can find the link to copy to go to your page, we will.
Okay.
But otherwise, we're looking at Virginia Women's Center and Terri Page, nurse practitioner. And
Yes.
is it a doctorate? Is
I
it,
did
do
get
they
my,
call you,
yes.
do they call you Dr. Terri
They
Page?
call me Terry.
Okay. Okay. I
And
love
I'm
that.
fine with that. I'm fine with that.
Good. I like it. I like it. Well, Terry, this has been absolutely incredible, super informative. I'm so grateful for this. And I hope that there is some young lady listening out there that her mother sent her this and said, you need to listen to this because this is all the stuff that happens and that they are inspired to take care of their body. Because that's really what this is
I learned
about,
a lot
taking
too,
care of
Heather.
ourselves.
I learned a lot from you as well. I appreciate the invitation. I had a really great time, informing the masses.
Yeah, this was awesome. Thank you. Thank you for listening and asking the question, hey, Heather, what about? I hope we inspired you to create a lifestyle for longevity. You deserve it. If something sparked a shift for you today, don't keep it to yourself. Pass it to a friend. Leave us a review to help others find us. Be sure to hit that follow button so you never miss a moment of real talk and real transformation. Ready to start your wellness journey? Visit theexquisitehouse.com to join us in the studio or learn more about The Plan, our signature program for nutrition, movement, and midlife transformation. And remember, keep asking questions. I'll be here with answers.